Sometimes life throws you a curveball. Maybe you're in the hospital unexpectedly or recovering from surgery, something like that.
Mhm.
Or even just dealing with something that, keeps you from moving around as much as
Mhm.
usual.
Right.
And then maybe you hear the words blood clot, and it can feel like stepping into a whole different world of medical stuff, right?
Yeah.
It's easy to feel a bit overwhelmed.
Oh, it really can be.
Yeah.
And the thing is, blood clots in the veins, what doctors call venous thrombosis, they're actually surprisingly common.
Yeah.
And understanding them does involve wading through quite a bit of complex information,
Yeah.
which is exactly why these really detailed, expert-driven guidelines are so, so valuable.
Absolutely. And that's exactly the territory we're digging into in this deep dive. We're looking at a set of sources, but mainly these really comprehensive 2021 clinical practice guidelines. They're from the European Society for Vascular Surgery. And this isn't just like one person's opinion. It's a whole committee of international experts who've gone through just mountains of research to figure out the best approaches.
It represents a huge amount of work, really. Countless hours of review, debate,
Mm-hmm.
you name it. And, it's worth just pausing for a second to remember the human side of this.
Mm-hmm.
These guidelines are actually dedicated to Dr. Clive Kieran. He was a really pivotal figure in thrombosis research, a key reviewer for this very document who sadly passed away. It just kind of highlights the dedication involved.
That's a really powerful reminder. So, yeah, while these guidelines are written for doctors, for healthcare professionals, our mission today is sort of to be your guides through them.
Exactly.
We want to pull out the most important bits, the understandable insights for you. Maybe you're trying to make sense of a diagnosis, or you're supporting someone you care about, or you just want to learn more. We'll unpack what the experts are saying, why, and what it might mean in, real life.
And crucially, this wasn't just cooked up in some lab somewhere. The process actually specifically included input from patients.
Oh, that's it?
Yeah, they actively sought feedback on what mattered from the patient's point of view. Things like making sure there were clear discussions about options like compression therapy or even procedures to remove clots.
That's so important, isn't it? Making sure the clinical advice is grounded in real people's experiences. Okay, let's get into it then. Let's start right at the beginning. What exactly is venous thrombosis?
Okay, so at its most basic level, it's simply a blood clot forming inside a vein. You can sort of picture it like a blockage, maybe like a traffic jam happening inside one of your blood vessels. It stops the blood flowing properly back towards the heart.
Right, a blockage. And the type we probably hear about most often.
There would usually be deep vein thrombosis, often called DVT. As the name suggests, these clots happen in the deeper veins. Most commonly, it's in the legs, but like we said, it can also happen in the arms.
Okay, so DVT is the main one, but you also hear about SVT sometimes.
Right, superficial vein thrombosis. These are clots in veins that are closer to the skin surface. People sometimes call it phlebitis. Now, while it's often less immediately serious than a DVT, the guidelines do point out that a superficial vein thrombosis can sometimes extend into deeper veins or even trigger a DVT.
Yeah.
So they definitely shouldn't just be ignored.
Got it. And then there's the big worry, the complication everyone is rightly concerned about.
That's the pulmonary embolism, or PE. This is what happens if a piece of that clot, maybe from the leg, breaks off, travels up through the bloodstream, and gets stuck in the blood vessels of the lungs.
Oh, wow.
Yeah, it can block blood flow there, interfere with oxygen getting into your blood, and tragically, it can be life-threatening. So a really major goal of treating any venous thrombosis is stopping that pulmonary embolism from happening.
That definitely puts it into perspective. How common is this whole venous thrombosis picture overall?
Well, the guidelines cite figures suggesting it affects about 1 in every 1,000 adults each year.
1 in 1,000. That's quite a few people.
It is, yeah. It's a significant number. And they particularly note how often it's linked to being in the hospital, sometimes called hospital-acquired thrombosis,
Yeah.
but also other specific situations that increase your risk.
So not exactly rare. And why does it happen? What are the sort of underlying reasons a clot might form or it shouldn't?
You can think of it like a kind of perfect storm, often involving 3 main factors that can interact. First, blood flow might slow down significantly. Second, there could be some damage to the inner lining of the vein itself. And third, the blood itself might just be a bit more prone to clotting than usual. Your body's clotting system is vital, right? It stops bleeding. But sometimes it just gets activated when it shouldn't be.
Okay, so slow flow vein damage and maybe stickier blood. What are the common things, the risk factors that can set up those conditions? What does the source material highlight?
The guidelines list quite a range of factors that can make you more vulnerable. Things like having recent surgery or significant trauma are pretty high on the list
Right.
because that often combines being immobile with potential injury to veins.
Mm.
And just being immobile for a long time, generally like being stuck in bed for at least 3 days, or even really long travel that can slow blood flow right down.
So sitting for hours on a plane or a long car journey, that's a real factor.
It definitely is. Other risks include having active cancer or other serious acute medical illnesses.
Hmm.
Being obese is a factor. Using hormone therapy that contains estrogen, like some birth control pills or hormone replacement therapy.
Okay.
Also, being pregnant or in that period just after giving birth. And critically, if you had a blood clot before, your risk of getting another one is much, much higher.
And what about genetics? Can that play a role too?
Yes, absolutely. Certain inherited conditions can make your blood more likely to clot. These are sometimes grouped together and called thrombophilia.
Thrombophilia.
Yeah. One example they mention, which might surprise people, is simply having a non-O blood type. That's associated with roughly double the risk compared to type O.
Wow, really?
Yeah. And another common inherited condition is called factor V Leiden. The guidelines talk about these genetic things, but the key takeaway for you listening is that these conditions can make you more prone to clots, especially if you also have other risk factors piled on top. They also specifically mention prolonged seated immobility, like spending hours and hours at a computer without getting up and moving, as another potential factor to consider.
That's quite a spectrum of things that can contribute. So, okay, if someone is worried or they have some of these risk factors, what are the symptoms they should be looking out for? And how is a blood clot in the vein actually diagnosed?
Right. So for a deep vein thrombosis in the leg, the sort of classic warning signs usually include pain, some swelling, maybe redness, and tenderness, often focused in the calf area.
Calf. Okay.
But if the clot is higher up, maybe in the thigh or even up into the pelvis, the swelling and pain can actually affect the entire leg. The guidelines even mention that sometimes unexplained back pain could be a symptom if the clot starts way down in the veins deep inside the abdomen.
Back pain.
Mm.
I wouldn't have immediately connected that. And you mentioned sometimes there aren't really obvious symptoms.
That's really crucial to remember, yeah. Especially if the clots are smaller, there might be very few symptoms, or maybe even none that you'd really notice.
Mm.
If the clot is in the arm, you might see swelling there, pain, the arm might feel warm, and sometimes it might look a bit bluish or discolored.
Okay.
And for that superficial vein thrombosis we mentioned earlier, the one closer to the skin, you'd typically see like a firm, thickened red and painful sort of cord-like vein just under the surface.
So the symptoms can be a bit vague sometimes, or they could look like other things.
Exactly. And that's one reason why diagnosis can sometimes be challenging. Things like a skin infection called cellulitis or lymphatic swelling lymphedema or even like a cyst behind the knee bursting, they can all mimic the symptoms of a DVT.
Right.
And doctors always have to keep in mind whether a pulmonary embolism might also be present, which has its own set of symptoms like shortness of breath or chest pain.
So how do doctors actually figure it out then? What's the process?
It usually starts with a healthcare professional, taking a really careful history, looking at your symptoms, and thinking about your personal risk factors. They might use a sort of clinical prediction tool, like something called the Wells score, to help categorize how likely they think a DVT is.
The Wells score.
Yeah, but the guidelines are really clear. These scores by themselves aren't definitive. Even if your score suggests it's unlikely, you could still potentially have a clot.
Okay, so symptoms, risk factors, maybe a score.
Yeah.
What's usually the next step?
Often it's a blood test called the D-dimer test.
D-dimer.
Right. This test measures tiny protein fragments that get released when a blood clot starts to break down. Now, if your D-dimer level is normal and your doctor thinks your clinical likelihood of having a DVT is low, then that test is actually very good at ruling out a DVT.
Ah, okay. So a normal result is helpful if the suspicion is low anyway.
Exactly. But here's the catch. A high D-dimer result isn't very specific just for a clot. Lots of things can make your D-dimer go up: pregnancy, having had recent surgery, infection, inflammation, even just getting older. So a high D-dimer means you might need more tests, but it doesn't automatically confirm you have a clot.
That makes sense. So if the D-dimer is high, or maybe the doctor was already quite suspicious.
Then imaging usually comes next. The guidelines point to ultrasound as the main imaging test used to look for these deep vein clots.
Ultrasound.
Yeah, it's non-invasive. They use a probe on your skin to look at the veins and see if they compress normally when they apply a bit of pressure. A vein that has a clot inside won't compress properly.
I see.
Sometimes, if the situation's a bit complicated or maybe the ultrasound isn't totally clear, then more detailed scans like a CT scan or an MRI might be needed. Or sometimes they might just repeat the ultrasound after a few days.
All right, so let's say the tests confirm it, a clot is found. How do the guidelines recommend treating it? What are the main goals?
Okay, the core goals are really threefold. First, stop that clot from growing any bigger. Second, prevent that dangerous possibility of a piece breaking off and traveling to the lungs, so preventing the pulmonary embolism. And third, reduce your risk of having another clot down the road.
Makes sense. And the
Yeah.
primary tool for doing all that?
That's anticoagulation. Most people know these as blood thinners.
Blood thinners, right.
Now, it's really important to understand what these medicines actually do. They don't work like, some kind of drain cleaner to instantly dissolve the clot.
Ah, okay.
Instead, what they do is prevent the clot from getting any bigger. And that gives your body's own natural systems the time they need to gradually break down and absorb the clot over, weeks and months.
Got it. So what are the different types of blood thinners they use?
Often, the initial treatment, especially if you're maybe admitted to hospital, starts with injectable medicines, things like low molecular weight heparin or maybe unfractionated heparin. These start working relatively quickly.
Injections first.
Often, yes. Then you're usually switched over to pills for the longer-term treatment. Now, there are the older medications, like warfarin, that's a vitamin K antagonist.
Yeah, I heard of that.
Right. And the thing with warfarin is it requires regular blood tests, usually called an INR test, to constantly monitor the level of thinning and adjust the dose to keep it in just the right range.
Okay, regular monitoring. And what about the newer options?
Those are the direct oral anticoagulants, or you might hear them called DOACs.
POACs.
Yeah. You might recognize names like apixaban, rivaroxaban, edoxaban, or dabigatran. A big advantage of these DOACs is that they generally have more predictable effects in the body, and they usually don't require that routine blood test monitoring that warfarin does.
Ah, that sounds potentially easier. But thinning the blood, doesn't that sound a bit risky in itself? What's the main downside?
You're right to ask. The main risk with any anticoagulant, any blood thinner, is bleeding. The guidelines really emphasize this point strongly. Doctors have to carefully weigh your individual risk of having another clot against your risk of having a bleeding complication.
Hmm.
That balance is absolutely critical when they're deciding which medicine to use, what dose, and for how long. They also mention that reversal agents do exist for these medications now, which can be really important if serious bleeding does happen. And they also briefly mention a rare but serious reaction to heparin called heparin-induced thrombocytopenia, or HIT.
Okay, so it's a careful balancing act. Now, once you're on blood thinners, how long do you typically need to take them? Is it like a set time for everyone?
This is one of the really key insights the guidelines reinforce. The duration of treatment is absolutely not one size fits all. It really depends most heavily on why you developed the clot in the first place.
Well, you got it.
Exactly. The guidelines classify clots based on whether they were provoked or unprovoked.
Can you just break down that difference, provoked versus unprovoked?
Sure. So a provoked clot means there was a clear, temporary trigger event that is now resolved. Think something like having major surgery or significant trauma, or maybe a temporary period where you were completely immobile. The trigger is essentially gone now.
Okay.
An unprovoked clot means either there wasn't an easily identifiable temporary cause, or perhaps the cause is something ongoing, like having active cancer.
Right, I see. So how does that affect how long the treatment lasts?
Well, for a DVT that was clearly provoked by a major temporary risk factor, like that major surgery example, the guidelines generally recommend about 3 months of anticoagulant treatment.
3 months.
Roughly, yes. And this is a Class 1 recommendation, which means there's strong evidence behind it and broad agreement among the experts.
Okay. What if the cause was something persistent, but maybe not active cancer?
Right. If the DVT was provoked by a persistent risk factor, something ongoing but not active cancer, because cancer-associated clots are handled a bit separately, then treatment might need to go longer than 3 months. But your doctor would need to regularly reassess your risk versus the bleeding risk. The evidence leans in favor of this longer treatment, making it a Class 2A recommendation.
Got it. And what about those unprovoked clots where you said the risk of it coming back seems higher?
Exactly right. If your clot was unprovoked, the risk of it recurring after you stop the medication is significantly higher. Because of that, extended treatment, often well beyond that initial 3 months, is very common. For this initial phase of treatment for unprovoked clots, the guidelines strongly recommend using one of the direct oral anticoagulants over the older medications like warfarin. That's another class 1 recommendation.
Okay, DOAC is preferred for unprovoked. And for that longer, potentially extended treatment phase.
Yes. For that extended phase, your doctor might recommend continuing anticoagulation for a long time, perhaps even indefinitely, especially if your risk of having another clot stays high. Now, the guidelines highlight something interesting here. For this extended phase, lower doses of certain DOACs can be a good option.
Lower doses.
Yeah, they specifically mention examples like apixaban at 2.5 milligrams twice a day or rivaroxaban at 10 milligrams once a day. This lower dose can help reduce the risk of bleeding complications while still offering good protection against clots coming back. The evidence supports considering this approach, rating it a Class 2, a recommendation.
So it really does come back to that constant weighing up the risk of another clot versus the risk of bleeding from the medicine.
Precisely. That decision on how long to continue treatment is always a shared one. It's made between you and your doctor, based entirely on your personal situation, your specific risk factors, your individual bleeding risk, and also your own preferences and what's important to you.
Okay. Now, beyond treating the immediate clot and preventing recurrence, what about potential long-term issues? I've definitely heard the term post-thrombotic syndrome mentioned.
Yes, post-thrombotic syndrome, or PTS. This is a potential long-term complication that can happen after DVT, particularly in the legs. It can lead to chronic issues like ongoing swelling, pain, a feeling of heaviness in the leg, skin changes like discoloration or thickening, and sometimes even painful skin ulcers.
Oh dear, that sounds really difficult to live with.
It can be, yeah. It happens because the original clot can actually damage the tiny valves inside the veins, and it can also cause scar tissue or blockages. All of that disrupts the normal flow of blood back up the leg over time.
So how do they try to prevent that from happening or manage it if it does?
One common strategy involves using compression stockings. These aren't just regular socks. They're specialized stockings that apply graduated pressure to the leg, tighter at the ankle and getting gradually less tight as they go up the leg.
Compression stockings.
Right. Now, in the short term, while you actually have the acute DVT, wearing them can definitely help reduce pain and swelling. The guidelines give this a strong Class 1 recommendation.
Okay, helpful for symptoms initially. What about using them long-term, specifically to try and prevent the PTS itself from developing?
This is where the evidence gets a bit more, well, nuanced. The guidelines suggest that wearing compression stockings may help reduce the risk of developing PTS in the long run. This is rated as a Class 2, a recommendation, meaning the weight of evidence tends to favor it, but it's not quite as definitive.
So it might help, but it's not a guarantee.
Exactly. Study results on this have actually been somewhat mixed over the years, but it seems that if you do choose to use them, wearing them consistently is probably important. If you tolerate them well and don't have major symptoms, wearing them for at least 6 to 12 months is often considered reasonable. Studies haven't definitively shown much extra benefit from wearing them for longer than that, though.
And are they suitable for absolutely everyone with a DVT?
No, that's a really important point the guidelines make. They caution that compression stockings are not appropriate if you have severe problems with the arterial circulation in your legs, the blood flow down to your feet, or if you have significant heart failure.
Okay, good to know. What about the idea of trying to remove the clot early on? Does sort of getting rid of it quickly help prevent that long-term vein damage in PTS?
That's exactly the theory behind procedures designed to remove the clot early. These often involve using catheters, thin tubes, inserted into the vein to try and break up or suck out the clot. The idea is to restore normal blood flow as quickly as possible and hopefully minimize damage to those delicate vein valves.
Right. Is this recommended for all DVT cases then?
No, this is actually an area where there's quite a bit of ongoing discussion among experts, and the guidelines reflect that complexity. It is definitely not recommended as a routine treatment for everyone with a DVT. The guidelines suggest that early clot removal may be considered, notice the may, in very carefully selected patients. This gets a Class 2, a recommendation. Specifically, this approach is most often discussed for patients who have very extensive DVT, particularly clots that affect the large veins high up in the groin and lower abdomen, what they call iliofemoral DVT. And usually only if those patients also have very severe symptoms.
So extensive clots, severe symptoms. Why isn't it recommended more broadly, say, for clots just in the calf or thigh?
Well, the guidelines explain that studies comparing early clot removal to just standard anticoagulation for clots limited to the calf or thigh haven't actually shown better long-term outcomes in terms of preventing PTS.
Ah, I see.
That gets a Class 3 recommendation, meaning the evidence is either against it or there's just no agreement that it helps in those cases. Plus, and this is important, these clot removal procedures themselves carry a higher risk of bleeding complications compared to simply using blood thinners alone. So it's really a treatment reserved for specific, severe situations where the potential benefits are thought to outweigh those increased risks.
That really helps clarify that complex issue. Now, the guidelines also spend some time looking at managing venous thrombosis in special populations or particular circumstances. Can we maybe highlight a couple of those?
Absolutely. Pregnancy is a really significant one. The risk of getting a venous thrombosis is substantially higher during pregnancy and also in that period right after giving birth.
Higher risk. Okay.
Yeah, and in places like the UK, it's actually a leading cause of maternal death, which is just a stark reminder of how serious it can be in this group. Diagnosis is also trickier during pregnancy. Normal pregnancy itself causes D-dimer levels to rise, which makes the D-dimer test unreliable. And the clinical prediction tools like the Wells score also don't work well. So the guidelines specifically recommend against using D-dimer or Wells scores to diagnose DVT in pregnant women. That's a Class 3 recommendation.
Wow. Okay. So how is it treated during pregnancy then if the standard tests aren't reliable?
If a clot is confirmed, usually through imaging like ultrasound, the recommended treatment throughout the pregnancy and continuing for at least 6 weeks after delivery is therapeutic doses of injectable low molecular weight heparin.
Those injections again?
Yes. This is a strong recommendation, Class 1. The older vitamin K antagonists like warfarin and the newer direct oral anticoagulants are generally avoided during pregnancy due to potential risks to the developing baby or the newborn.
Got it. What about patients who also have cancer?
Yeah, cancer-associated venous thrombosis is another really crucial area. People who have active cancer, unfortunately, have a significantly higher risk of both having recurrent clots and experiencing bleeding complications while they're on blood thinners. It's a tough situation.
Sounds very challenging.
It is. The guidelines note that both low molecular weight heparin injections and the direct oral anticoagulants are often used in this setting. And typically, the treatment needs to be continued for as long as the cancer remains active, reflecting that ongoing high risk of clotting.
Right. And what about those inherited clotting conditions we touched on earlier, the thrombophilias? Does having one of those change the treatment plan?
Usually having an inherited thrombophilia doesn't change the initial treatment for an acute clot. You still get the standard anticoagulation. However, it often means you have a higher underlying risk of getting another clot once that initial standard treatment duration is finished. So for certain high-risk types of thrombophilia, like having severe genetic deficiencies or particular patterns seen in a condition called antiphospholipid syndrome, the guidelines actually recommend lifelong blood thinning medication. That's a Class 1 recommendation.
Lifelong.
In those specific high-risk cases, yes. And there's a very important caution here from the guidelines. For one particular type of antiphospholipid syndrome, often called the triple positive kind, the direct oral anticoagulants should not be used. That's a Class 3 recommendation, meaning evidence suggests harm or lack of benefit. In those cases, warfarin is the preferred treatment, which gets a Class 2, a recommendation.
That's a really specific, important distinction. Are there other special groups, like people with kidney disease?
Definitely. Kidney function is vital because our kidneys are responsible for clearing many medications from the body, including most blood thinners. So if your kidney function is impaired, the drug levels can build up and increase the bleeding risk. Managing anticoagulation in patients with kidney disease, especially if it's severe, requires really careful dose adjustments and often closer monitoring.
Makes sense. And body weight extremes were also mentioned, right? Being very thin or having obesity.
Yes, the guidelines note that as well. Significant variations in body weight at either end of the spectrum can affect how medications are absorbed, distributed, and metabolized in the body. So again, dose adjustments and careful consideration are necessary in those situations too.
It's pretty impressive how detailed these guidelines get, trying to cover so many different scenarios. But you mentioned earlier that research is still ongoing. Are there still areas where the experts feel like they need more answers?
Oh, absolutely. The committee that put these guidelines together didn't just summarize what we know now. They also very explicitly identified key questions where more evidence is still needed.
Like what kind of questions?
For instance, they'd like better ways to diagnose DVT, particularly those clots that are just confined to the calf veins, which can be tricky. They're still working to pin down the absolute optimal duration and the best type of blood thinner for many specific clinical situations. The precise role And the true long-term benefit of those early clot removal procedures for different types of DVT is still being actively researched and clarified.
Interesting.
They also highlighted the need to better understand why there seem to be racial differences in how often DVT occurs, and how best to manage venous thrombosis in specific groups that are often underrepresented in trials, like children, pregnant women, and those with severe kidney disease or at the extremes of body weight.
So even the leading experts are saying, we've learned a lot, but there's still more to figure out.
That's exactly right. Medical knowledge isn't static. It's constantly evolving as new research comes out.
Okay, so as we wrap up this deep dive into the expert guidelines on venous thrombosis, what should be the main takeaways for you, our listener?
I think the big picture is that venous thrombosis, while it's a significant health condition, is something that, with proper diagnosis and the right treatment tailored to your specific situation, can be managed effectively. The most serious risks, like a pulmonary embolism, can be significantly reduced, and the risk of having another clot can also be managed.
And the key principle.
The fundamental principle that runs all the way through these guidelines is that treatment has to be highly individualized. It needs to take into account why you got the clot, your personal risk factors, your individual risk of bleeding, and importantly, what matters most to you, your preferences and values.
And the best way for you, the listener, to navigate all this potentially complex information.
Really, don't hesitate to have a thorough, open conversation with your healthcare providers. Talk about your symptoms, your personal risk factors. Ask them why a specific treatment or a specific duration is being recommended for you. Ask any questions you have, big or small. These guidelines provide the framework for doctors, but ultimately, your journey and your care are unique to you.
That's really excellent advice. And maybe here's a final thought for you to mull over as we finish. Think about how much incredibly careful work and analysis went into creating these comprehensive guidelines by leading experts from around the world. Yet those same experts themselves identified numerous areas where we still need more research, more answers. What does that tell us about the nature of medical understanding? Perhaps that it's not some fixed destination we arrive at, but more like an ongoing exploration, always refining, always learning, always seeking better answers for individual patients like you.